CTD signs and elicitation techniques. 1. Malar or butterfly rash is seen in systemic lupus erythematosus. It matters because it is a classic cutaneous marker of SLE and often photosensitive. To elicit, first ask, do you notice redness or rash after sun exposure? Inspect the face in natural daylight. Look for erythema across the cheeks and nasal bridge, sparing the nasolabial folds. For example, a young woman reports rash after beach visits, and you observe the classic butterfly pattern. 2. Discoid rash is seen in cutaneous lupus. It matters because it indicates chronic cutaneous lupus with risk of scarring and pigment loss. Ask about persistent scaly patches or hair loss. Inspect scalp, ears, and cheeks. Look for circular plaques with central hypopigmentation and peripheral hyperpigmentation. For example, a middle-aged man with scarring alopecia and discoid lesions on the scalp confirms the diagnosis. 3. Oral or nasal ulcers occur in SLE and Behçet's disease. They matter because painless ulcers are a diagnostic criterion in SLE, while recurrent ulcers suggest Behçet's. Ask, do you get mouth or nose sores often? Use a torch and tongue depressor to inspect palate, buccal mucosa, and nasal septum. For example, a young adult with recurrent oral ulcers and genital sores makes you consider Behçet's. 4. Raynaud's phenomenon is seen in scleroderma, mixed connective tissue disease, and SLE. It matters because it is an early vascular sign and may precede systemic sclerosis. Ask, do your fingers change color in cold? If unclear, provoke with cold water or spray. Observe the triphasic change: white from ischemia, blue from deoxygenation, and red from reperfusion. For example, a teenage girl with finger color change during winter may be showing the first sign of CTD. 5. Sclerodactyly is typical of systemic sclerosis. It matters because it is pathognomonic and reflects skin fibrosis. Inspect the fingers for tight, shiny skin. Attempt to pinch the skin, it will be bound down. Look for claw-like deformity. For example, an elderly woman with difficulty gripping objects has tight skin over fingers confirming sclerodactyly. 6. Calcinosis cutis occurs in Crest syndrome. It matters because it indicates chronic tissue damage and calcium deposition. Palpate elbows, knees, and fingertips. Feel for firm, gritty nodules under the skin. For example, a patient with Crest and painful fingertip lumps shows chalky nodules suggesting calcinosis. Telangiectasia is seen in systemic sclerosis and Crest. It matters because it reflects vascular dilation and is part of Crest criteria. Inspect face, lips, and hands under bright light. Look for fine red lines, especially perioral and on fingertips. For example, a patient with systemic sclerosis has telangiectasia on lips and cheeks supporting diagnosis. 8. Gottron's papules are seen in dermatomyositis. They matter because they are specific and help differentiate from psoriasis. Inspect knuckles, elbows, and knees. Look for violaceous, flat-top papules. Compare the scale. It is finer than psoriasis. For example, a woman with hand rash and muscle weakness is diagnosed with dermatomyositis after Gottron's papules are seen. 9. Heliotrope rash is also seen in dermatomyositis. It matters because it is pathognomonic but often missed unless inspected in daylight. Ask about eyelid swelling or itching. Inspect eyelids in natural light. Look for violet discoloration with puffiness. For example, a patient with periorbital rash and fatigue is confirmed to have dermatomyositis with heliotrope rash. 10. Proximal muscle weakness occurs in polymyositis and dermatomyositis. It matters because it causes functional impairment and is a key diagnostic feature. Ask, can you climb stairs or comb your hair easily? Perform chair rise tests without using arms. Assess shoulder abduction. Grade power using the MRC scale. For example, a patient struggling to rise from a chair has proximal weakness, suggesting inflammatory myopathy. 11. Joint changes are seen in rheumatoid arthritis and overlap connective tissue disorders. They matter because joint deformities signal chronic inflammation and overlap syndromes are common. Inspect hands for symmetry and swelling. Palpate joints for warmth and tenderness. Check range of motion and look for ulnar deviation, swan neck, or boutonniere deformities. For example, a patient with morning stiffness and hand deformities likely has RA overlap with CTD. 12. Nail fold capillary changes are seen in scleroderma and dermatomyositis. They matter because they show early microvascular damage and are useful for diagnosis and monitoring. Apply immersion oil to nail fold. Use a dermatoscope or magnifier. Look for dilated tortuous capillaries or capillary dropout. For example, A young woman with Raynaud's has nail fold capillaroscopy showing capillary dropout, supporting early scleroderma. Dr. Yogesh summarizes, summary of signs, associations, and elicitation techniques. Malar rash in SLE, inspect in daylight, ask about sun exposure. Discoid rash in cutaneous lupus, scalp and ear inspection for scaly plaques. Oral or nasal ulcers in SLE and Behçet's, torch exam of mouth and nose. Raynaud's and scleroderma, MCTD and SLE, cold exposure test or history. Sclerodactyly and systemic sclerosis, pinch test for bound skin. Calcinosis cutis and crest, palpate for gritty nodules. Telangiectasia and systemic sclerosis and crest, inspect lips, face, and fingertips. Gottron's papules and dermatomyositis, dorsum of hands, compare with psoriasis. Heliotrope rash and dermatomyositis, eyelid inspection in daylight. Proximal muscle weakness in PM and DM, chair rise, arm lift, MRC grading. Joint changes in RA and overlap CTD, symmetry, deformities, range of motion. Nail fold capillary changes in scleroderma and dermatomyositis. Dermatoscope with immersion oil.